Well, just in the interest of time, thank you all for joining. This is our first virtual tumor board of the new year. So it is Wednesday, January 8th, 2025, and really excited for the first session of the calendar year. Special thanks to Trevor Hackman and the Salivary section for helping organize this. I'm Mike Moore from the CDMS, and thanks to all of you who have joined us. Just as a quick reminder for those who aren't familiar with the format, it'll be 3 cases, about 20 minutes each, meant to be a kind of guided discussion based on our moderator's direction. Thanks to the fellows who have put together what sound to be some very thought-provoking questions. I will man the chat box, so please enter any questions or comments or things that you'd like to bring to the discussion of the group in there, and I'll bring them to Trevor, and then we'll go from there. So really excited for the session. Thank you all for being here. If you're not speaking, please mute just to try and minimize background noise. So thanks.
Awesome. Thank you, Mike. Thanks for the support from the CDMS. We've got a star-studded panel, so I won't take up too much time. So on the panel, we have Dr. Stefan and Don and Dr. Blake Sullivan from UNC, presenting a case, Dr. Gabriel Pule and Lindsay Moses from NYU, Amin Armanian and Omar Karadaji from Kansas University, and then our discussants, Dr. Will Ryan from University of California, and then Alexandra Keshner scrubbing out at MUSC. But I'm really looking for these cases. I think they're going to be very thought-provoking and hopefully stimulate some questions and some learning. I will direct us to start with Dr. Andan and her presentation.
Hello, everyone. Let me just get this shared. All right, can everyone see that okay?
Yes.
All right, so I'll just start in. This is a case of patient JK. She's a 71-year-old woman who was referred for evaluation of a right parotid lesion. Her medical history is listed here on the right. On initial presentation, she reported a right parotid mass that had been slow growing over the course of a year, causing occasional discomfort. She had no noted neck masses. On exam, she was noted to have a firm inferior parotid mass abutting the tragus, no overlying skin changes. Her facial nerve was fully intact and symmetric bilaterally, and she had no palpable neck masses. A parotid ultrasound was done in April, shortly after her initial presentation, and I'll show a representative clip here. I'll just go back so we can slower through the ultrasound.
And while we're doing that, Dr. Ryan and Dr. Keshner, any thoughts on the ultrasound? Do you use this often in your practice? And if so, any thoughts about the imaging?
Yeah, I love using ultrasound. I have my whole career. I do it on most new patients I see, particularly salivary patients. I think the real-time aspect of it is nice. Sometimes I don't have scans on patients either because they haven't arrived in our clinic or they don't have them at all. You get a sense of the location of the tumor and what all might be going on and what the surgery might entail.
Any risk factors you look for in ultrasound that sort of raise your alarm bells, if you will?
Alex, you want to go?
Yeah, as you say, so some of the things looking for kind of like an infiltrative pattern. If it looks like it's kind of harder to see the separation between muscle and tumor itself, in part of it is also the clinical aspect, right? Like when you are palpating it, you also feel like how fixed is it, but the ultrasound kind of gives you a little bit more information about the deeper portions if it's got irregular borders. Also can tell for lymph nodes, which is nice. I'm a little bit of a late adopter because we had a really, really old ultrasound, but I know a lot of the youngsters now have the butterfly and the fancy ones that you can use in the clinic, but it is very, very handy, as Will mentioned, and also can assist for in-office biopsy, especially if you have difficulty getting access, can give an idea of how deep these are as well and what their extent is.
Yeah, that's a great point.
Hypervascularity calcifications can indicate malignancy. Nothing's totally pathognomonic though. Lack of deep enhancement is a sign of malignancy, and anechoism is usually benign.
All right.
Those are the main things.
Why don't you go on, Stefan?
Okay. A parotid FNA was also done, and this is a representative photomicrograph from the FNA that she had that shows clusters of oncocytic cells with bland cytologic features. The pathology was read as a low-grade oncocytic neoplasm favored to be a Warthin's tumor, though an oncocytoma was also in the differential.
I don't love that band that's superior and anterior to. That's not a finding you usually see. At first, I thought it was a dilated duct, but that wouldn't make sense in the location of the tumor. And tumors don't usually cause obstruction of ducts. That's a strange.
Yeah, I couldn't tell if that was an artifact or not.
Yeah.
All right. So moving-
She shortly after
Facial nerves 100%.
facial nerve is 100% correct.
And also a greater rate of her sensations intact.
She had no sensory deficits on her exam. Shortly after her FNA, she had a CT neck with contrast that was done, and I'll just quickly scroll through that here. And just going through the neck portion too.
Ultrasound is a better way to look at neck lymph nodes, actually.
Mhm.
So
I'll
it's
scroll back.
it's a bigger scale to see the fatty hyla, or if that's absent. Is that yeah, that's still present, that offshoot extension.
Can't tell if that's a facial vein.
Yeah, it might be, but you wonder.
Okay.
It's close to the stylomastoid foramen. That's the biggest finding.
Right. And the official read for the CT was an enhancing mass of the parotid gland that involved both the superficial and the deep lobes. No obvious findings on CT to suggest any sort of perineural spread, although that's not obvious on CT. And there's no cervical lymphadenopathy.
And what
and then just
do is that especially when you have these sort of deeper tumors, I feel like occasionally the accuracy of the FNA can sometimes be a little bit off when they're that deep. And there's something to kind of consider too, because that, you know, when you see it in the office versus seeing it on the scan too, I think that's another thing to kind of look at.
Good point. Would anyone do any additional imaging workup at this time, or would the CT and ultrasound suffice at this point?
I think if I knew it was definitely benign, which we don't, I would be okay proceeding. In fact, I'm okay proceeding if it's just an ultrasound and benign, but I usually like MRI if there's a chance of malignancy.
And I think on your needle right now, you're being told by your histologist that it's benign, right? Warthin's tumor, oncocytic, no signs of cellular atypia.
I saw
But you have to type-
low-grade salivary neoplasm, right?
Yeah.
Favor Warthin's, but favor is not that's a hedge.
Correct.
And I, you know, I kind of hold off on MRI for the most part, unless there is like a question of, you know, perineural invasion or something like that, or occasionally you'll have a patient who wants to avoid surgery really, really badly. And so sometimes MRI can give you a little bit of a differential diagnosis based on the density findings on there, but it really depends on whether or not the radiologist is comfortable calling that. And so, you know, it kind of depends on where you are and where you're practicing. And so it's never going to be a slam dunk as much as tissue will.
And just to highlight Dr. Kesher's point, when these deeper tumors are there, when you're inserting the needle, unless you have the hub completely plugged, you can trap some of the salivary tissue in that first 2 centimeters before you get to the tumor. If the tumor is very dense, most of what you might have in your needle might be the salivary tissue adjacent to, just to keep that in mind. All right. Where'd you go next?
So in this case, an MRI actually was obtained, and I'll go through that. So she had an MRI that I'll scroll through here. And I'll just stop there since you know there's no neck adenopathy. The official read for the MRI was that there was an 3 centimeter enhancing lesion in the posterior right parotid gland that seemed consistent with the biopsy of an oncocytoma versus Warthin's tumor. No obvious metastatic disease, but there was a question of facial nerve enhancement at the in the mastoid segment near the stylomastoid foramen, and I'll just show that's what this arrow is pointing to. Right there.
Can you go, I guess it's
Looks like you have similar activity on the
inferiorly
side.
run through the MRI a bit more
Sorry?
to show the parenchyma of the parotid again.
The parotid. Mhm.
Yeah, right there. I mean, maybe that's the FNA tract inflammation, but that looks weird. That extension matches the ultrasound a bit.
Mhm. So for the sake of time, I'll just go on to what we did next. So the patient was consented for parotidectomy with facial nerve dissection, proceeded to the operating room. Intraoperatively, she was found to have a large multilobulated tumor that involved the deep and superficial lobes of the parotid gland, as we knew. The tumor was adherent to the facial nerve main trunk and the pes. Frozen specimens were taken at that time from both the parotid parenchyma and the proximal parotid duct, and frozen pathology was suspicious for possible carcinoma, though they couldn't make a definitive call on frozen section. A subtotal parotid resection was performed, and the decision was made to leave the facial nerve intact, although notably at the end of the case, the main trunk of the facial nerve was not stimming.
So for our discussants, you get in, you got the malignancy diagnosis. Your thoughts on the nerve and what to do and how radical to go in this kind of scenario.
So if it's grossly involved and we have, a suspicious for carcinoma, I usually will go and talk with the family and kind of, say, okay, this is a potential. And I usually actually bring it up, even with those MRI findings, I would have probably counseled them on it. If it's not adherent and it peels off easily, there is some data to show, and it's primarily in the cutaneous literature but it doesn't change overall outcomes, sacrificing the nerve if you can peel it off easily, because if they usually get treated with adjuvant radiation. And so, but if it looks like it's grossly into the nerve, I usually will take that nerve. Again, making sure that the patient is aware ahead of time if I can, and if I can't, I'm usually talking with the family.
How much does the facial nerve function preoperatively impact your decision, Will?
Usually. I'm really a facial nerve preserver at almost all costs, and I am in the minority, I know, nationally for that. And some of my fellows, we've had these moments like this, and I save it, leave microscopic tumor behind and radiate. And I think, Alex, you mentioned there are a few studies. They're mostly international, I think Australian, German, and Korean, that I've sort of logged away for my own legal protection in these scenarios, that the outcomes are the same. So it's the biology of the cancer, and your surgery is not going to change that. The radiation is what's going to. So I don't love resecting facial nerves, but I totally acknowledge that I'm not typical in that way. But I don't think it'd be really hard to prove either way well, right? You're not going to randomize anybody ever. So it's a very challenging situation.
And notoriously tough too if you've got inflammation and you don't have a definitive diagnosis on frozen.
For sure. I wouldn't take a nerve if, in this scenario where you thought sounds like the prevailing theory was it was Warthin's, and you're really surprised. If you know it's a low-grade cancer going in, it's a bit easier to maybe make that decision because you've gone algorithmically through it with the patient. But for them to be surprised and wake up with a paralyzed face would be pretty tough. whether it's really indicated or not. So you might have considered a mastoidectomy in this situation for a couple of reasons. Number one, it was right at the style of mastoid foramen. I'm pretty low threshold for doing that. It's kind of nice. I can do another case while the otologist is doing the mastoid anyway. And then it was a bit infiltrative looking. So, and there was that finding of possible vertical fallopian canal involvement.
Yeah, I'm the same with the for the drilling out the mastoid. I think it kind of helps because then even if you have to graft it, then you have a nice little tunnel you can put the nerve graft into, and gives you some access, and also sometimes the ability to kind of figure out where that's going to.
I had a patient maybe 4 years ago. Safan, you might have been around. Safan was our resident at UCSF, and it was a low-grade cancer in an orthodontist. So you wonder if it was from dental imaging, but did the operation, and this tumor was pretty adherent to her facial nerve. She was preoperatively intact, and we just dissected everything free. It was kind of a mess, She was weak afterwards, but she came back full 100%, radiated her. It's been 4 years. She's fine. That's a one-off. But then my daughter's orthodontist ended up being her best friend, and she was like, "Oh my God, Dr. Ryan, you saved my friend." And, it was just a nice moment. So it's stuck. It's these kinds of things stick out in my mind, and the quality of life is preserved.
Did you get a discount on braces too?
No, I was thinking like, oh, I'm in there. It's like $4,000.
All right, Savant, why don't you pop on to the next
All
slide?
right. So surgical pathology returned as a high-grade salivary gland neoplasm with oncocytic features, most consistent with a high-grade mucoepidermoid carcinoma. And this is also just another representative photomicrograph from her permanent pathology from that parotid resection. Tissue was also sent to neogenomics for a salivary gland fusion panel, and a mammal to CRT-C1 fusion was detected, which can kind of confirm this mucoepidermoid carcinoma diagnosis. Additional immunostains were also done, and everything was consistent with mucoepidermoid carcinoma. Patient's case was presented at Tumor Board, and ultimately she returned to the OR shortly thereafter for a mastoidectomy with facial nerve dissection. The nerve was transected at the second genuine proximal nerve margin, was sent for pathology. She had a completion total parotidectomy, and the nerve at the stylomastoid foramen was also resected and sent as part of the parotid specimen. She had a right neck dissection, levels 2 through 4, a left adipofascial ALT free flap for reconstruction to fill a defect, and then also additional facial reanimation procedures. And final pathology returned as listed here. The proximal facial nerve margin was negative for malignancy. In this specimen, she had an additional 0.5 centimeter focus of residual mucoepidermoid carcinoma, negative margins, no PNI or LVI, and all nodes, the juxtaparotid and cervical nodes, were negative for malignancy. Given the original tumor that was excised plus this re-resection, she was staged as a PT3N0 high-grade mucoepidermoid carcinoma.
So the nerve wasn't invaded at all?
No.
Yeah. And these are tough cases, right? Because you're doing so much dissection to preserve the nerve, and then it's weak afterwards, and the inflammatory reaction. How many passes, Will and Alex, do you do with an FNA on a parotid mass? If you do it, I don't do a ton. I sometimes do a lot. I take a lot out without even biopsying them. But if you're suspicious, is one sufficient? Do you think that doing 3, you might get more cellular sample? Because it seems kind of odd that you'd have a Warthin's and pathology would mix a Warthin's up with the mucoep.
Yeah.
I do some FNAs when they're deep lobe like that, just to be on the safe side. A lot of times I will have interventional radiology do it. Don't hate on me. But the other thing that we'll sometimes get, and you have to be careful for Warthin's, of course, and this is definitely controversial, but if I'm concerned, sometimes I'll have them also do a core to get some more information. Now, you do have the chance to seed with that, but certainly, that does help. Our pathologists, cytopath folks, will usually do between 3 to 5 passes for the parotid tumors. And then for the cores, I think they just do 2 if they feel good about it.
Yeah, sometimes I just do one. I don't know, but I always wonder, like, what do you think, Will?
I mean, there's passes in that one setting, and then there's the notion, do you repeat the FNA another day, when you get one of these specimens? I think there's decent literature to suggest that repeated FNAs, for the most part, do not yield a new change in a change in diagnosis from like an ambiguous situation. So,
Yeah.
um,
But at the time of the FNA, do you do just like one pass, three,
I
two?
don't do my own FNAs. We have this amazing ultrasound guided cytopathology unit right below our clinic. It's a walk-in. It's extremely convenient. They're really
Wow.
good. We just do it. Yeah. It was set up about 5 years ago.
It's fancy.
It's
Fancy.
fancy. It's amazing. Yeah. So I trust that they do it well. Now there is varying degrees of confidence I have in certain pathologists. I've got to the point where I kind of know the best, but they're all pretty good. So anyway, so I don't know that kind of technicality, to tell you the truth.
Gotcha. Dr. Sullivan, any highlights or things you wanted to highlight about the case?
Yeah, thanks. Nice job, Stefan. I think as a young faculty, the point I took away from this case and another case is that even if you have a benign preoperative result now, I will still say, after this case specifically, I will say, even though we have a benign preoperative biopsy, there is always a very low risk that that was an inaccurate biopsy and it could change our intraoperative plan. And so I now mention that to everybody, and then documentation and notes because of this case. They initially, I think, on the pathology had thought it was going to be salivary ductal, and then they had to do additional staining. So it was kind of a sneaky tumor. But fortunately, at the end of the day, she's done well. She just finished radiation. I'm actually going to see her on Monday. So thankfully, at the end of the day, everything worked out well for her.
I think that's a great point, Dr. Sullivan. I have been practicing long enough to tell you that I've gotten caught in the OR with a surprise, and you always remember your surprises. For sure.
We all had this scenario. If you do a lot of salivary tumors, you're going to get this situation. It's hard. It's really hard.
And one thing that I usually will tell patients with the consulting, because like I said, all of us, we run into your like that, all the clenching of the world and every single sphincter. But one thing from a counseling standpoint, when I talk to patients, I say, there's a less than 1% chance of any permanent weakness unless you have tumor that happens to be growing around here. And, the majority of these are benign, but sometimes they have little pieces inside of them that are not. And so that kind of prepares them for the worst, because when if it goes well and they wake up happy, then you've, undersold yourself and they're really happy. And then if you have to, then they know that it's, a possibility.
Awesome. All right. Thank you, guys. Stefan, thank you so much for getting us through that presentation. Gabriel, why don't you kick off with your presentation?
Yeah, let's go ahead. Let me see. Can you see my screen?
Yep, you're good to go.
Okay. So, hi, everybody. I'm Gabriel Pujol. I'm the fellow at NYU Langone. I'll be presenting alongside Dr. Moses, who's my mentor for this case. So we're going to present patient AA. She's a 57-year-old female who was found to have a tongue mass on October 2023 by her dentist. The tongue mass was not causing any symptoms, and the review of symptoms was relevant only for implant weight loss since April of that year, after she had undergone a gastric sleeve surgery. Her medical history is listed here. It was non-contributory. On physical exam, she had a submucosal mass in the right ventral tongue, about 1.5 centimeters in diameter, abutting the midline. The tongue was mobile and the floor mouth was soft, and the neck was negative for masses or adenopathy. You can see here in the clinical picture, it's a pre-submucosal mass on the right side of the ventral tongue. So what should we do next? Well, we went ahead and
So Will and Alex, you're seeing the patient clinic before you even get imaging. Would you stick this thing with a needle? Would you get imaging first? What's your go-to?
I like imaging because I have had a couple of hemangiomas pop up in this area. and have been very happy that I didn't stick a needle beforehand. I was like, oh, this feels nice. It'll be good. And then it was phleboliths that I was feeling. So that's usually because tongues are weird.
Mhm.
You know, probably would needle it. You know, you're not supposed to open biopsy these. It's probably a bad idea, but it looks fairly small. I mean, what's it, centimeter and a half?
Yeah.
Yeah. See if a needle gets you information.
Do you ultrasound, Will? Do you put the ultrasound in the mouth?
On the tongue. There are little sticks that transducers that can do that. I think we have one. I never, because I always kind of thought to use it for floor mouth stones, but no, I haven't. I don't do that.
Yeah, the vaginal probe actually works really well in the mouth for this to kind of take a look at those kind of things and tell you whether
The
it's
idea
vaginal or
is
not.
like keep your mouth.
Yeah. All right. Go ahead, Gabriel.
Yeah, so the patient had actually undergone incisional biopsy at an outside hospital. It showed adenoid cystic carcinoma with cribriform and tubular growth pattern invading the skeletal muscle. I think the other slide skipped. Sorry about that. So afterwards, the patient got a PET scan on December of that year and showed ill-defined activity in the anterior tongue, 5.8 SUV, and then non-specific nodes bilaterally on levels 2 SUVs, 3.3 on the right, which is where the mass was, and 2.7 on the other side. So after that, an MRI was ordered, and it showed the lesion again. You can see it here. I don't know if you can see my cursor, but we can see it here enhancing as well as over here on the PET. But all the nodes that we're seeing on the PET were basically non-specific as well on the MRI. 1.5 centimeter level 2 on the right, and then 1.3 on the left.
All right.
So
yeah. So what are you guys thinking?
How old is the patient again?
How old? 57.
57.
Yeah.
Well, it's a super rare situation,
Mhm.
first of all, but it is what it is. I mean, I want to make sure those nodes aren't something. It sounds like they're not. Mostly adenoid cystic doesn't metastasize as easily, but I think oral cavity has a little stronger tendency to do so.
Yeah, I agree that the pattern that they're describing with the skeletal muscle invasion and then the cribriform, you had a mixed pattern of tumor, it sounded like, on the incisional biopsy. So that would put me at a higher alert rate for performing an elective neck on this patient. It's kind of lateralized, but I mean, it looks like it was getting closer to the midline. So I think one option to really truly assess those nodes, as Will had mentioned before, is that ultrasound can be actually a lot more reliable in distinguishing whether or not a node is suspicious looking. Because you don't want to put someone through a bilateral neck dissection for if they don't truly need it. But yeah, that's kind of where I would look at.
Any thoughts you guys have on this neurotropic disease and what you're going to do to manage the major nerves of the tongue?
Yeah.
Was this patient have any anesthesia of the tongue or anything preoperatively, Gabriel?
Yeah, no anesthesia and no problems moving the tongue.
I think there's a very strong tendency for adenoid cystic carcinomas wherever they are to have an infiltrative pattern and a perineural component. And my feeling is that chasing that and trying to clear the margins is not the best for the patient, and instead radiation afterwards is what should do that. But I guess I give it an effort to some degree. There's some cord of tumor tracking down the lingual nerve grossly, sure, sacrifice it, but otherwise leave it alone. So surgery first is the treatment that I would propose for this.
Yep.
Possible neck dissections. And I mean, Alex, what do you think about reconstruction here?
So, I think ideally you want to get the gross tumor margins cleared. So I agree with the tracing perineural is just very challenging, but I would probably opt for a true quarter gloss, I guess. So taking a good portion of it. And depending on it looked like it was very, very well circumscribed. So I think taking a good, 1.5 to 2 centimeter margins around it. Then for reconstruction, a lot of times I found that, we do tongue reconstruction so that it looks pretty, but it doesn't necessarily add a lot from a functional standpoint. So unless there's truly like floor of mouth communication, or if there's a significant loss of tissue bulk that would cause a speech impediment, I oftentimes actually will not do a lot. If it's just like a quarter tongue for hemigloss, I will. But that's kind of I might be the weird heretic on the, the recon group for that, because a nice hemi tongue recon is very, very fun and happy to do. But that's kind of what I've seen in my experience.
We don't really know, about whether to reconstruct with a free flap here or not. I did a small study on skin grafts for not minor salivary gland cancers like this, but although I think we had one in it, but mostly T1, T2, and CIS squamous cell carcinomas. And the one thing we found on doing questionnaire outcomes on patients was anterior floor of mouth did not have great speech outcomes with skin grafts. Everything else was fine and pretty much back to normal when there was floor of mouth involvement. So this is getting towards the anterior floor of mouth. So it's one reason I consider a radial forum, but it might just be something you could excise, close primarily, and there's no tongue tethering at all, and then radiate the rest.
And I do like sometimes for those areas too, the buccinator myomucosal flap or a submental, because they can be local.
Submental be good. Submental be good. Because it's going to get radiated either way, so you're not taking up lymph.
Right.
That's always
Gabriel, what did you guys do?
Okay, thank you. So we had a tumor board discussion. The patient was staged clinically as a T1 and 0 M0, stage 1. The adenopathy on imaging was felt to be non-specific after discussion. And then, so the surgical plan consisted of a right partial gloss with a left radial forearm plus or minus tracheotomy based on the swelling after the case. No plan for elective neck dissection due to it being a low-grade tumor based on the histologic grading and the clinical staging. Adjuvant treatment was to be determined on the final path. So we went ahead and had the right partial glossectomy and partial floor mouth resection. 1.5 centimeter margins were taken. And then a right level 1B neck dissection was done for vessel exploration, and left radial forearm flap used, and the trach was used as well. So the tumor was abutting the midline. It included the anterior 1/3 of the oral tongue on the right, and it extended across midline with defect and into the floor mouth. All of the margins taken were negative on frozen sections, and the right level 1B nodes were removed, and the submandibular gland was preserved. So
with that resection, I would do a radial forearm. Just to be clear. It's interesting to preserve the submandibular gland. I do that a lot as well. I think it cuts down a fistula rate for this scenario, probably. There's a Scottsdale Mayo paper that looked at that a long time ago.
It as a flap too, Will.
As a what?
As a flap.
What do you mean?
Submandibular gland flap.
You bring it up to the tongue, you mean?
I haven't brought it up for the tongue, but I have used it for floor mouth defects where the everything around the submandibular gland was clean. You can pop it up in there, or for a tonsil too.
Right, because it closes off the space. Right, makes sense.
But yeah, it doesn't preserve salivary gland function.
Well,
So I'll throw this out to
get radiated anyway, so it's not going to do that well.
I'll throw this out to Gabriel and to Dr. Moses. So in this scenario, I agree, some sort of recon, whether it be a forearm or a submental flap, makes a lot of sense for the tongue tethering that Dr. Ketchner pointed out earlier. Replacing floor mouth and having some movement of your tongue independent of the mandible is important. If you're already in the neck doing the vessels for the forearm flap, the additive time of doing like a level 1 through 3 neck dissection is probably like 30 minutes. We don't really know. We know that submandibular gland adenoid cystics have a higher rate of nodal metastasis, and we know that they don't really have a high rate in parotid. Minor salivary glands have a high rate of nodal metastasis. Was there a consideration, since you're already in the neck, just to take those lymph nodes out, and this or not?
Yeah, thanks. That's kind of the crux of this case. And so, I think there was a lot of discussion about that back and forth, both at the tumor board and with the patient. The patient, her daughter was an SLP, works with head and neck patients. She came in very kind of educated about her own disease and what she wanted. And so, she was interested in prioritizing tongue mobility and speech, minimizing incision size, minimizing postoperative lymphedema, things of that nature. And so there was a discussion about it. I was actually the reconstructing surgeon for this case, so I didn't do the primary tumor resection, but that was kind of the reasoning behind it. The lymph nodes that were removed were really just for exposure and kind of a minimally invasive, incision there to do the anastomosis in the neck.
Awesome. Thanks. That's very helpful. All right. Sorry, Gabriel. Go ahead.
Yeah. So the primary tumor on final pathology was a 1.9 centimeter anoicystic with cribriform and tubular patterns, no solid components. All margins were negative, no LVI, and it had multifocal PNI which was intratumoral, and the largest nerve was 0.4 millimeters in diameter. Here are some sections of the PAP slides to review. And then with the neck dissection specimens on the right level 1B lymph nodes, there was one that was positive for adenoid cystic carcinoma with a 7 millimeter focus and microscopic ENE of less than 1 millimeter. And here's an image of that slide as well. Okay, so where would we go from there?
Yeah, Dr. Moses has a great flap in there, so now you got to go in. And what do you do?
You radiate that puppy.
Yeah, I would just radiate. You could go back and try to do a neck section levels 2 through 4, and even 1A, but you're gonna bag the marge mandibular nerve, maybe cause some problems, delay radiation, maybe depending on your scheduling. Elective radiation for occult nodes is pretty effective for salivary gland cancers in the few studies that have looked at that. You have that as a backing to that plan. Now, it's not totally wrong to go back in either. It might improve their regional control if you can do it in a timely manner and you feel good about your dissection skills in a previously dissected neck.
Does the E&E aspect of the nodal involvement change that thought process at all?
I mean, I think this is one where the head neck in us says, well, if there's E&E, then they need chemo, but the data really, doesn't show there's that much of an improvement with these patients. And so, it is especially in a patient who's very concerned about their, overall functional outcomes and things like that. It may be, it's worth the discussion, I think.
And then how do you temper that with the fact that the distant risk factor is probably not modifiable with that? Right? The distant lung disease, like I'm assuming there's a risk for that. So yeah. All right. So Gabriel, what do you guys do?
TOG 1008. I think it's either accruing or there's some problem with the quality of life outcome measures. I don't know. That's what Suyam told me, our radiation oncologist. But that's looking at randomizing patients to cisplatin or not with salivary gland cancers.
Yeah.
That would help answer this question of systemic treatment or not with this, but we don't really know, and I generally don't favor it. It doesn't seem like it on retrospective studies. That's helpful.
All right, Gabriel, what do we do now?
Okay, so we did a follow-up tumor board discussion shortly after the surgery, and we restaged the malignancy as a pathologic T1 and 2A M0, so stage 4A now. And the consensus was to do a completion bilateral neck dissection given the positive node with ENE and the primary tumor being located very close to the midline, abutting it on the ventral tongue, and then would add adjuvant radiotherapy to the primary tumor site and to the bilateral necks. So went ahead with the completion neck dissections. findings included like a moderately firm node at level 1A, but all the other nodes were not suspicious, and all the cranial nerves and vessels were intact at the end of the case. Final pathology showed all of the nodes to be negative after the dissection. Okay, and patient received adjuvant treatment, 60 grays of IMRT to the oral cavity and bilateral necks given 30 fractions, which she completed on April of 2024.
Serendipitous nodal removal during your forearm free flap, finding the one positive node.
Yeah.
Okay.
That was the most likely site, right?
Yeah.
Fortunately, she knows an SLP, so it'll be all right.
Yeah. All right.
So on follow-up, the C surveillance imaging has been negative, last being on September, and clinical follow-up has shown no evidence of disease at last follow-up. So discussion points that we wanted to bring up, was this tumor CN0 or CN positive to begin with?
Mm-hmm. That's tough.
I think ultrasound
right?
might have, I really do think ultrasound might have seen that. I'm like a huge advocate for ultrasound. I've always used it.
Mhm.
I see stuff the in tumor board our radiologists don't see. And it's just huge advantage. So sometimes that might have caught it. I can't say it definitely would have, but it might have. Particularly if there's E&E, it probably would have.
Yep, agree.
Yeah, based on pre-op imaging, would you have lowered your threshold for maybe doing an FNA?
Yeah, I mean, we kind of mentioned that, right? That we were thinking about that, and so
yeah.
And
the other discussion point,
it's hard to know. You know, I understand why everything happened the way it did. It's fine. I mean, and the management was decent. It really was.
and another discussion point is, should we manage minor salivary gland carcinomas based on their histology or their location?
Both.
Me.
So yeah, so for location, the minor salivary glands, if it's in the larynx or something like that, then the likelihood of nodal metastasis is pretty low. But oral cavity and soft palate and really not nutrient rich, lymph node rich areas do carry a higher risk. And the fact that, they saw skeletal muscle invasion, I think is another one that probably shows it's a little bit more of an aggressive subtype. But yeah, I think that, if it's a minor salivary gland tumor of the hard palate, then your likelihood is a little bit less than if it's in the tongue or the floor of mouth or the tonsil or something like that.
I'd highlight that per your case, you were respecting the patient's wishes. They wanted to be minimally invasive in what they did, not much surgery. I would say probably the one thing I could think of is knowing that you weren't going to do an ectosection, but you took out, there was a sampling of a lymph node or two and not an extraction. That might be the time that I might send those for frozen, knowing the fact that if they're positive, then things might change, and then you have the ability on the table to pivot. Now, whether they call it unfrozen or not, I don't know, but I would think that they would see abnormality in the lymph node unfrozen, and that may be something to consider in a case where you're not planning an ectosection, but you're still sampling lymph nodes, because then the ultimate question is, why send the lymph node, right? Because once you send it, then you open yourself up to potential for having to go back. And yeah, that's a tough one, because the patients have to be able to drive what they want to do, and many times there's specific goals that they have, and we have to respect those.
That's a very good point. And I know we discussed this earlier in the case about having done a upfront elective neck dissection on this patient, but taking that point, would you have included a contralateral neck given the tumor's met light abutment?
I would have, like as we mentioned with Will, like I think that with the PET scan and everything, I would have done the upfront ultrasound to the contralateral neck, and then if there were anything on there, sampling those. Because especially if there's nothing radiographically on that side that looks concerning, then I think you could consider just elective radiation to that side as opposed to doing a bilateral neck potentially. But I don't think it's a wrong answer. I don't think anybody would be like, oh wow, why would you do bilateral? Because it does abut the midline. And for squamous cell carcinoma, we know that makes a difference. I think for the rarity of oral cavity minor salivary gland tumors, it's just the data is not there to say one way or the other.
Yeah, I think that's a great point. The data is just not there, right? We have a lot of parotid malignancies, pretty good amount of submandibular, but minor salivary gland, and to your point, Gabriel, the location being like, is it hard palate, soft palate, tongue, buccal? That the data is not awesome, and so I think making the decision to observe for a negative PET MRI versus doing a neck, I think we have like level C, if not D, evidence on what to do.
Very
All
true.
right, that was a great
Yeah.
case, Gabriel. In the
Yeah.
interest of time, I'm going to move on. We'll probably
Yeah.
go a few minutes over for a meeting, but thank you so much, Gabriel and Dr. Moses, for a great case.
Really cool case. Really the
Thank
challenge.
you.
The whole spectrum of things you could do there. So it's not.
Definitely.
All right, so I'm just going to move on to the next case. So this is a 68-year-old male with a left talar parotid mass that's been present for 6 months with mild interval growth in the past month. There's no overlying skin ulceration with no associated pain, no facial weakness, no history of prior skin cancers, no prior head neck cancers or treatment with head neck radiation. Past medical history is significant for dyslipidemia and OSA. He had an outside pathology of this mass via a core biopsy that showed a neoplastic squamous epithelium being present, and they threw in the differential diagnosis of a squamous cell carcinoma versus a mucoepidermoid carcinoma. On physical examination, the patient had a left 1.5 centimeter mobile mass along the talar parotid. No overlying skin ulceration. It was non-tender on palpation. Facial nerve was intact. No visible skin lesions or scars in the scalp or face. No cervical lymphadenopathy. And oral cavity and oropharyngeal examination was normal. This is a contrast-enhanced CT showing a 1.3 by 0.9 centimeter soft tissue mass along the superficial aspect of the talar parotid. And there's no pathologically large cervical lymph nodes.
His left side, that little.
Yes.
Yeah, that little guy over there, superficially parotid tail. Okay, right there. That one.
Yeah.
That is
Mhm.
nice.
So we had some questions for the panel, but maybe
Yeah.
I'll let Dr. Hackman drive that.
No, by all means, you guys questions, fire away. Yeah, so what's your thought process? I think I like this first question. So the rarity of the primary cutaneous carcinoma of the parotid versus the poorly differentiated mucoep versus the occult cutaneous lesion that resolved. So what do you do to try and work up that conundrum?
A dermatologic exam, or I look myself, but I don't usually find anything too concerning. I mean, if there's some huge ulcer in their scalp, take a biopsy. But this happens a lot. I mean, I think it's like the second or third most common entity in the parotid that's a malignancy because of, and it depends on where you practice. Probably if you practice in really sunny areas, then there's more skin cancers. So I, as far as treatment, I mean, we now have immunotherapy, right? But the problem with this case is that there's this thought it might be mucoepidermoid carcinoma. If something was bigger and more concerning surgically with regards to risk, I might consider a neoadjuvant approach if we strongly understood that it was cutaneous squamous cell carcinoma. But with this being so accessible and low risk, I think surgery up front is best because your chance of cure is higher with that, and there's less side effects with some sort of neoadjuvant cemiplimab being used. But it's just suddenly popped up in my head as an option here.
What do you think, Alex?
So I think one thing too is that if you can get your hands on the outside core, sometimes they can do the mammal testing on there to see if they can differentiate it. And then that, as Will mentioned, the depending on the extent the cemiplimab can be really nice for cutaneous ones. I'll say, given that the appearance of this little fella, he looks very friendly compared to some of the ones. And so I think that it's hard to get people chairs for infusion. So if it is something that's easily surgically resectable, then you may be able to save it for when they recur in their lungs or something like that. Just kidding. I'm not being that pessimistic.
Yeah, no, I agree.
I think that's a great point for use of medical resources. Like I think that's a great point. And so I'm a big parotid preserver. I rarely do total parotids, even
Yeah.
for malignancy. So what is the scenario? Is this the scenario you would do a total parotid, or what would be the scenario that you would do a total parotid?
Oh, go ahead, Alex.
Okay, so usually, yeah, I have to be pushed to take the whole parotid out. So if I'm like sacking nerve and I'm like, I know it's going to the duct, but I think I'm in the same boat because it's not a thyroid gland, it's loose areolar tissue around there. So I think if you can resect it and clear it with nice margins around it, I try to preserve what I can, especially if it's a tail, you can find like the nice little marge, bring them down. If it truly is a salivary gland tumor, I would include the neck with it. But yeah, I think I tend towards, and I think maybe it's from the silendoscopy background where we want to preserve those glands, but
Well, there's 2 or 3, maybe 4 lymph nodes in the parotid. They're usually superficial to the facial nerve. You can use ultrasound to find them and remove those. You can just dissect and take them out, like plucking them, right? I mean, yeah, you're not taking lymphatics, I guess, but there's lymphatics from some point of the skin going through the face or the scalp or the ear to that parotid anyway. You're not taking those. So you're not really, I don't think, doing anything that's completely an extensive full operation for this patient. I would add a neck dissection, 2 through 3 with external jugular nodes to this, and posterior 1B.
All right, I mean, go ahead.
So we did a superficial parotid for this patient. We did get a frozen section as well, which was positive for squamous cell carcinoma. So then because of that, we included a selective neck dissection levels 2 to 4. So our follow-up questions was going to be, what is the utility of frozen section in your practice? And do you typically refer these kind of patients to any other specialists?
I would say that for frozen section, salivary glands can be notoriously hard, especially if you have a really high grade muco-up, because they can look so much like squame, and depending on where they're sampling the tumor from. So if you're like sending the whole thing down and they're cutting it in the middle and that kind of thing, versus like, did they get a peripheral edge? Or if you have a very cutaneous tumor. So I use it? Yes, all the time. And then for other specialists, yeah, I mean, we'd do the tumor board discussion and, for less likely radiation, depending on your final pathology, but it kind of depends on your final path.
Yeah, I don't really use frozen sections much at all, I'll say. I don't know. Trying to think of what I would do here to guide a decision intraoperatively, because that's why you use frozen sections. I don't think it would guide me. I would do basically what you did, probably a little less of a parotid than the full superficial parotid for the reasons we just described, but it's not wrong to do a full parotidectomy.
And yeah, if in the consideration, like if we didn't know muco-up versus cutaneous, when it's a cutaneous one, I usually actually for both things, I usually do 2B. I don't know if you, Will and Trevor, you also do that, but I usually do include 2B and 1B. But a lot of times I'm also putting a submental in.
I am too, and I usually will add in 5, like upper 5. All right, go ahead.
I usually take 2B if it's, I kind of say, I think I've said this to various residents, like if it's easy, take it. If it's somehow really hard, you feel like you're stretching the nerve, just leave it alone. It's pretty unlikely to have, if there's an obvious node in it, take it out. But I usually take it.
Perfect. So the final pathology came back as, again, a squamous cell carcinoma, 1.1 centimeter deposit involving 2 intraparotid lymph nodes. So it was felt to be from a cutaneous primary, unknown primary. The neck dissection had 15 nodes, none of which were positive. And these are some of the pathological slides, essentially showing the squamous cell carcinoma in the nodes and then the adjacent normal parotid tissue, which again speaks to the non-primary portion of the SCC and likely from cutaneous origin. So this is the patient postoperatively. Then the question was whether you would offer this patient adjuvant treatment and what types.
I would highly recommend radiation in this scenario.
Agree.
And probably the radiation oncologist have the extent of radiation that varies. Hopefully there's some history of a skin resection 2 years ago or an ablation that you can target, but I think sometimes those drainage pathways are ignored during radiation. So that's the hard part. Where's the primary? Does it still matter? It may not, but
Yeah, did the primary like regress like you could see sometimes in Merkel cell?
yeah, maybe. I mean, it's hard to know.
It's hard to know. And then and I think I probably would get this patient in to see a dermatologist because even though we don't have the primary, we're assuming that they had one and they may have other ones, so they need a routine dermatology follow-up from here on in. Would anybody get additional like ancillary testing for future stuff? Like
PD-1.
like PD-1 or anything like that, or would you just wait for the recurrence?
If it recurs, we either use the biopsy or go to the original path and get it out of the archive and test it then. I think probably for costs, and then like you're not going to treat them now.
Yeah.
We may learn that adjuvant immunotherapy is of strong interest in this scenario. I mean, we're doing that with melanoma now, right?
Yep. And breast cancer.
Yeah. So that I bet that will be favorable, highly of high utility. But
it's a good plug for the upcoming meeting. There's a combined cutaneous and salivary section looking at this exact topic, like the growing role of immunotherapy up front, adjuvant. What are we doing? And I think it's a exciting area for our fellows to be a part of. And I strongly recommend that you all plan on being a part of it because even though you think, oh, it's medical oncologists that are treating it, surgeons have to be involved in the decision making, how this is done, and how we treat these patients, biopsy management afterwards. And I think there are plenty of trials that are ripe for the doing in the coming years.
Yeah, as I say, I have my fourth completely negative neck dissection after ipi-nivo, and with like palpable, like radiographically positive appearing nodes. So great news for the patient, great news for me, but it is kind of like, okay, now what do we?
Hey, Karen, I see your hand up.
I would get rid of radiation in that scenario. Ultimately, we'll have to see.
I was just gonna say, NRG just activated Neil Gross's trial for neoadjuvant cemiplimab, and so I think this case, if we could have proved that it was parotid metastatic cutaneous, would be treated hopefully, like Will said, with neoadjuvant, and then the question becomes, what's the role for surgery? How much surgery to do, and then do you do adjuvant radiation, adjuvant cemiplimab, and that trial is hopefully going to answer that question.
Yeah, I guess so. Dr. Karadashi, if say you had given this patient neoadjuvant, and then you get like a response, would you have adjusted your operative plan from the superficial parotid neck? Would you have done the same thing? Where do you think you would have been?
I think that's the $1 million question, and I think that's the question we're always asking back and forth. I think even though this is all kind of off trial data, we would have absolutely sort of narrowed our resection and maybe have done just a superficial parotid focusing on that tail region as opposed to doing a more comprehensive. I think we've seen some various degrees of results in our practice in the neoadjuvant setting. A lot of times not seeing any signs of residual disease. So I think this is sort of an exciting era, and I look forward to seeing some data come of this for some guidance, really.
Yeah, I agree. I think I probably would have shrunk it down to the parotid too. Probably not done the neck. Alex, Will, what do you think?
Yeah,
I agree with that, but I still would have done surgery up front here because in most of our hands, it's 100% likely to get that tumor out safely, right? Whereas cemiplimab is like 65% chance it's going to shrink it down. So that's not a great difference to me. And you have the side effects of immunotherapy. 30% of the time there's some problem. 10% of the time it's some major problem. So if there's some caked on tumor adherent to the mastoid, you know, 3 lymph nodes positive in the neck as well, yes, cemiplimab up front.
yeah.
So
See,
surgery is going to be way more dangerous. You're going to take the facial nerve, this huge thing, flu flap. So you try to spare him of that problem and hopefully help his distant metastatic risk in the meantime.
yeah, I say same thing. Like the ones that I have done post immuno have been ones that were facial nerve involvement or temporal bone involvement. That would have been, they would have been buying themselves like a big resection, possible free flap, maybe radical neck dissection, and then we do a response-based surgery afterward. And I think that is Neil Gross's study the one that's just like the immuno and radiation alone, or that one has surgery too? Because there's one that we were trying to open up here that was just immunoradiation alone. So
Yeah, that it's response adapted surgery, and some surgery is going to be required, but it can be a small surgery, so it'd be based on the response.
Yeah, and that gets to my question, because this patient had 2 nodes positive, right? We gave him post-op rads. If they had a complete response to immunotherapy, they don't get radiation therapy. And I hear Dr. Ryan's point about the side effects of cemiplimab and immunotherapy, but I also think about the long-term effects of radiation therapy. And if I can avoid giving my patient radiation, is that worth the potential response versus side effect for cemiplimab? I don't have that answer, but I just float that out there.
That's a great point. And in that preliminary study, a number of patients refused. I don't remember the number, but a significant, meaningful sample of patients after neoadjuvant cemiplimab, then surgery, when they had or when they had a complete response, a number of them refused radiation, and the follow-up that they had, almost all of them were still fine. Short follow-up, but that was pretty interesting, and I think it has a high potential to be the way this goes, like you're saying, which would be awesome.
Yeah, we haven't given adjuvant radiation therapy for, I think, the last year and a half if they have a CR. So I think
What's happened with melanoma. We used to radiate melanoma. I've been out 15 years. We would do these next sections on melanoma and radiate them. Like, now it's like you never do that. So,
I mean, do you have other slides you wanted to offer up?
No, this is the last slide of this case. I mean, we did have a couple of other spot cases, but I think we're getting to the end of the session anyways. So, but this is the last slide.
Gotcha. Well, awesome. Any other closing thoughts, Dr. Karadashi, about the case?
No, I think we touched on a lot of the interesting developments with the immunotherapy, and we touched a little bit on the extent of the superficial parotid. One thing that is always difficult to ascertain is that if we think this is an occult metastasis from a cutaneous, then do we approach the parotid like we'd approach a neck and want to do this in sort of a therapeutic, sort of systematic fashion? And I think these are all kind of interesting challenges with this particular entity.
Well, I want to thank our panelists and discussants for really keeping this session going and providing some really thought-provoking cases. So thank you all for your time with this, and Will, Alex, for your expertise, especially coming out of the OR. Alex, I thank you so much. Mike, I'll turn it over to you.
Yeah, no, thanks so much, guys. Great cases. I think that's why we love and hate salivary tumors, just because there's such a challenge, so much nuance, and there's such a heterogeneous group with different behaviors that I think it always pushes us to really think them through, just to make sure we're guiding our patients down the right path. And these cases, I think, really highlighted that. So thank you so much for putting it together. Trevor, thank you for great organization, fantastic job moderating the session, and to Safan, Gabriel, and Amin, awesome cases. Thanks for putting them together, and thanks to Blake, Lindsay, and Omar for being your faculty mentors. And of course, Alexandra and Will, I really appreciate your expert experience as well. And Kieran for calling in as the boss of the salivary section. Thanks to all the fellows. This was very well attended. Really hope you got a lot out of it. I certainly did. Our next session is on February 5th, Wednesday. It's on skull-based tumors. So excited to see you there, those who can make it. So have a great night, everybody. Take care.
Thank you, sir.
Okay, thanks for organizing.
Thank you all.
That was outstanding. Thank you.